Hello everyone, my name is Seung-Hyup Kim, Professor of Radiology at Seoul National University Hospital. In this session, I would like to talk about the role of imaging in uterine cervical carcinoma. Uterine cervical carcinoma is a significant public health problem because it is the most common gynecological malignancy worldwide and is the worldwide leading cause of cancer-related deaths of women, especially in developing countries. This world map shows estimated cervical cancer incidence and this map shows estimated mortality. As you see, both incidence and mortality of uterine cervical carcinoma are high in underdeveloped or developing countries. Cervical carcinoma has the oldest history of staging system in the literature back to 1928. In 1950, International Gynecological Congress proposed International Classification System, and in 1958, first FIGO staging system was introduced. Until 1994, there were 7 revisions, which was mostly substaging of stage 1, and the final revision was done in 2009, which included substaging of 2A into 2A1 and 2A2. This is the latest version of FIGO staging system. Among these, the most important part in terms of imaging staging is presence or absence of parametrial involvement. Until now, preoperative CT or MR imaging is not officially incorporated in the FIGO staging system, and the reason is because cervical carcinoma is most prevalent in developing countries where imaging resources are limited. In other words, because of lack of universal availability. However, the revised FIGO staging system acknowledges the benefits of staging on the basis of MR imaging findings and encourages its use when available. If you search Google with keywords of cervical carcinoma MRI, you will find 2 of 3 most often cited scholarly articles are published by our team, and here Kim is myself. This is one of those 2 articles published in 1990 in Radiology, and we compared the CT and the MR findings in the same 30 patients group. And the result shows that MRI staging was much better than clinical or CT staging in terms of parametrial invasion and overall staging accuracy. This is another one of those 2 articles which was published in 1993, and we compared accuracy rates of CT and MRI in the same 99 patients group. And the MRI was superior to CT in every aspect of staging, including sensitivity of tumor detection and accuracies of parametrial extension, overall staging, and pelvic lymph node metastasis. There was a meta-analysis paper in JAMA in 1997 on lymph node metastasis in cervical cancer patients. Our 2 articles were also included in this meta-analysis. This is a table for CT sensitivity and specificity, and quite high specificity with relatively low and variable sensitivity. And this is for MRI, and it also shows high specificity with low and variable sensitivity. This low sensitivity is probably due to frequent metastasis found in normal-sized lymph nodes. There was another systematic review comparing CT and MRI staging of cervical carcinoma. In this study, as you see, MRI is superior to CT in most of the staging components. This case of cervical cancer clearly shows why MRI is better than CT. On CT, only we can notice is that uterine cervix is large, but we cannot tell which area is tumor and which area is not. It is hard to predict parametrial status also. However, with MRI, T2-weighted images, we clearly see that most of the cervix is involved by tumor except these low-intensity areas, and left parametrium is clearly involved. But CT had advantage over MRI in far advanced cases because it can cover whole abdomen easily. We see large cervical mass and metastasis to liver and para-aortic lymph nodes. What is the basic MRI protocol we are using? We obtain T2-weighted images in all three planes, axial, coronal, and sagittal, and we add oblique axial or oblique coronal if necessary. We take T1-weighted images in axial plane, including abdomen, to cover kidney and the para-aortic lymph nodes, and we add diffusion-weighted images with p-values of 0, 50, and 800, and dynamic contrast enhancement in at least 4 phases. That is our routine MRI protocol for uterine cervical carcinoma. Lesion is usually well demonstrated at T2-weighted imaging as a high-intensity tumor on the background of low-intensity cervical stroma. In this case, the lesion is well circumscribed by a low-intensity rim that represents preserved normal cervical stroma. It means that the depth of invasion is not full thickness, and 80% depth of stroma was involved in this patient. Here is a patient with larger cervical mass, but again, thin peripheral low-intensity rim is preserved, and so the stage will be 1B2, and depth of invasion in this patient was 9 mm out of 11 mm. If there is disruption of low signal intensity cervical stromal ring, it indicates that the lesion probably has full thickness stromal invasion. Here is an example case, and a large cervical mass, low intensity stromal ring is preserved in these areas, but destroyed in the other areas. In this patient, there was full thickness stromal invasion without parametrial extension. Here is another case with full thickness stromal invasion. In this case, cervical stroma is destroyed in this anterior part and is well correlated with pathologic results. Parametrium is the most important area for cervical cancer staging. Some literatures say that parametrium exists only at lateral sides, but as you see in the schema, also there are anterior parametrium as a form of vesicouterine ligaments and the posterior parametrium as uterosacral ligaments. Here is a case with left lateral parametrial invasion, this case with anterior parametrial invasion, and this case with both lateral and posterior parametrial invasion. Then, what are MRI findings of parametrial invasion? In addition to disruption of low-intensity cervical stromal ring at T2-weighted images, which indicates full thickness stromal invasion, there are irregular spiculated margin of cervical mass, nodular or irregular tumor mass extending into parametrium, and sometimes tumor encasement of periuterine vessels. Here is a case with left parametrial invasion. You can see irregular spiculated margin of left parametrium with encasement of periuterine vessels. Another case of stage 2B cancer, and we can see both right and left lateral and also posterior parametrial invasion in this patient. How about this case? Left and posterior parametrium is clearly involved, and also the lesion extends posteriorly along the left uterosacral ligament. Parametrium looks okay at sagittal plane, but coronal image well shows irregular lateral margins. So we need to remember that assessment of parametrium at all three imaging planes is important. There are pitfalls in parametrial evaluation, and sometimes it is difficult to determine whether there is parametrial invasion or not. Main reason for this difficulty is partial volume effect, usually due to adjacent vaginal phonics or secondary inflammatory changes in the parametrium. Here is a case with larger cervical mass and full thickness stromal involvement on the left side, and left parametrial margin is not clearly defined, but there is no definite irregularity or mass in the parametrium. As surgery and pathology, There was no parametrial invasion in this patient. How about this case? Just reactive change or true parametrial invasion? There was true invasion in the left parametrium in this patient. Again, how about this patient? True involvement or not? Not. This patient, yes, true involvement. Vaginal involvement is another area of staging but less important than parametrial invasion. If the vagina is involved, we can see thickening and disruption of low-intensity vaginal wall at T280 image, and the vaginal fornices are obliterated. Here is a case of cervical carcinoma in the anterior cervix involving anterior vaginal wall. Here is a large cervical mass growing into the posterior vagina with obliteration of posterior fornix, stage 2A cervical carcinoma. Here is another case of large cervical mass bulging into the vaginal cavity, but contrast-enhanced T180 image well shows that the vaginal fornices are not obliterated. Here is another patient with a cervical cancer with preserved vaginal fornices, which is well demonstrated at contrast-enhanced T180 image. Here are two different cases with involvement of lower one-third of vagina, so stage 3A cervical carcinoma. Bladder or rectal involvement is another very important part of staging. We have done a study on bladder invasion in 1997, and among a total of 300 patients with a cervical carcinoma, there were 12 cases with bladder invasion. MRI had 83% sensitivity, 100% specificity, and 99% accuracy in detection of bladder invasion. MRI findings of bladder invasion are segmental disruption of low-intensity bladder wall at T280 image and protrusion of tumor mass into the bladder. Infrequently, we encounter findings of a high-intensity band along the inner surface of the bladder wall on T280 image, representing bullous edema. FIGO staging clearly describes that a bullous edema does not permit a case to be allotted to stage 4A. Surgery was tried in this patient, but it was impossible to separate bladder from cervical tumor, so partial cystectomy should be done also. So according to FIGO staging system, this case is not stage 4A disease, but in practical point of view, this case should be considered as stage 4A. Here is a very old article published in 1961 in Journal of Urology entitled The Herald Lesion of the Bladder, a lesion which portends the approach of the cancer or inflammation from outside the bladder. In this report, 38 of 140 cases were due to uterine cervical carcinoma. 3 different patients with the cervical carcinoma showing Herald lesion at cystoscopy and the findings of bullous edema at T280 MRI, so MRI stage 4A cancer. 2 other patients with the same findings, and we usually see a strong contrast enhancement along the surface of this bullous edema. Now, let's move on to lymph node metastasis in cervical carcinoma. Although pelvic lymph node metastasis is not included in FIGO staging, it is definitely one of the most important prognostic factors in patients with cervical carcinoma. Pelvic nodes have various shapes. Some are round and globular, and some others are oval and elongated. Generally, round or global-shaped nodes have more chance of metastasis than oval or elongated nodes. Although maximum and minimum axial diameters are similar in a round lymph node, but are very much different in elongated lymph node. This is the study we published in 1994 in Radiology, and we evaluated pelvic lymph node metastasis with MRI. 1 cm criteria of minimum axial diameter had higher accuracy and specificity than 1 cm maximum axial diameter criteria. This is another study done by my colleague in 2006, and PET-CT had significantly higher accuracy and sensitivity than MRI with the same specificity in pelvic node evaluation in patients with uterine cervical carcinoma. This is a case of true positive lymph node in left external iliac chain. As surgery and pathology, there was one positive lymph node in left external iliac region, so this lymph node is probably that positive lymph node. Here is another case with true positive lymph node. Here is a small node in right obturator area, which is well enhancing and well shown at diffusion-weighted imaging and the ADC map. At surgery, there was one positive right obturator node, so we may consider that this node is positive. How about this case? There are multiple small lymph nodes in external iliac region, and the nodes are well demonstrated at diffusion-weighted imaging. There was no positive lymph node at surgery, so all these nodes are probably negative nodes. So the issue in pelvic node evaluation is how we can differentiate normal-sized normal lymph node from normal-sized abnormal or metastatic lymph nodes. Nanoparticle macrophage imaging may be a solution, but still it is not the stage for routine clinical use. Sometimes pelvic nodes show cystic or severely necrotic changes, and then they might be confused with ovaries. But differential point is that the lymph nodes are usually lateral to the nearby vessels. On the left side, here is a small parovarian or paratubal cyst medial to the pelvic vessels. And on the right side, here is a large node with necrotic changes lateral to the vessels and was confirmed as a metastatic node. There was an article mentioning that central necrosis of lymph node has 100% positive predictive value for metastasis in cervical carcinoma. Here is another patient with large necrotic metastatic lymph node. Still, we have controversy regarding the value of contrast enhancement in preoperative MRI of uterine cervical carcinoma. Personally, I think contrast enhancement is necessary because it often gives us useful additional information. For example, contrast-enhanced T1-weighted imaging clearly shows the extent of the tumor as compared with non-enhanced T2-weighted imaging. Here is a large fundal myoma and a mass in anterior cervix. This cervical lesion is better delineated at contrast-enhanced T1-weighted imaging. Here is another case where the extent of the lesion is not well defined at T2-weighted imaging, but is clearly demonstrated at contrast-enhanced T1-weighted imaging. How about this case? This is T2-weighted imaging and its magnification, and this is contrast-enhanced T1-weighted imaging and its magnification. On T2-weighted imaging, the lesion appears to involve full thickness of cervical stroma, but after contrast injection, we may notice that there is a thin layer of contrast enhancement that is continuous with normal cervical mucosal enhancement, indicating that the involvement depth is not full thickness. At pathology, depth of invasion was not full thickness, and the peripheral 4 mm was preserved, as we could expect at contrast-enhanced T1-weighted imaging. As I mentioned before, involvement of vaginal fornix is well demonstrated at contrast-enhanced imaging. That is another important finding in staging. This contrast-enhanced T1-weighted imaging while shows vaginal phonesis, indicating that there is no vaginal involvement. Another issue is the value of diffusion-weighted imaging. As you see in this case, diffusion-weighted imaging and the ADC map show the lesion with better contrast, and we can define the extent of the lesion more clearly. Here is another case in that ADC map clearly shows the parametrial extension to the right uterovesical ligament. Of course, diffusion-weighted imaging better demonstrates pelvic lymph nodes, but as I mentioned before, we have problem in differentiation of normal-sized metastatic lymph node from normal-sized normal lymph node. These are summary of my talk. MRI is the best imaging modality for staging of uterine cervical carcinoma. Preoperative CT or MRI is not officially incorporated in the FIGO staging system, but revised FIGO staging system acknowledges the benefits of staging on the basis of MRI findings and encourages its use when available. We need to be familiar with MRI findings of each stage of cervical carcinoma and the limitations. Thank you for joining this session, and if you have any questions, please email me.